Mhm. Okay. Bailey, we're good to go.
Good to go.
All right, great. So, welcome. Good afternoon, everyone. Welcome to the Newborn Screening Follow Up webinar hosted by the Maryland Department of Health, Office of Children and Youth with Specific Healthcare Needs, or you may hear me reference later as OCEAN. So, thank you again for joining us today. The topic is talking with families about newborn screening. We know that conversations with families during the newborn period can be emotional and complex. So, our goal for today is to share strategies, stories, and tools that support clear, compassionate, and respectful communication. We have a fantastic lineup of presenters today, including a medical provider who works closely with the newborn screening program and a mother that will share her firsthand experience. So, a couple housekeeping rules before we get started. This session is being recorded and will be available later for further viewing. Due to time constraints, we will hold all questions until the end of the session. Now, the chat is open. So as we go along, please feel free to put them in the chat box and we can answer them during the dedicated Q&A period. So with that being said, I will go ahead and get started with a brief overview of the newborn screening programs. And to introduce myself, my name is LaPortia Barrows. I am the program manager over the newborn screening blood spot and CCHD programs here at the Maryland Department of Health. All right, I'm ready. Next slide. So we do have a couple slides that go over our mission and vision. I will not read them verbatim to save everyone's ears, but I will briefly mention just to let you know that the Office of Children and Youth with Specific Healthcare Needs is a part of the Maternal and Child Health Bureau within the Public Health Services Prevention and Health Promotion Administration, which then falls under the whole big umbrella Maryland Department of Health. So now that I sent you guys through a whirlwind, let's move on. All right, so here's our schedule for today. And I will just be kind of going through and introduce each speaker as it comes up. Okay. All right. So, like I mentioned before, our objectives really is to just have those clear communication when we're talking with families. So, we're going to hear from the provider side and then we're going to hear from the family member side and get both perspectives so that we can add tools to our toolbox to better communicate and handle those situations. So there is three different types of screenings. We do have the blood spot, the hearing screen, and the heart screening. For this webinar, we will focus on the blood spot and the hearing screen. All right, so the blood spot screening here in Maryland, we do only two screens. And if you guys, I'm sure everybody's familiar, it's when we poke the little baby's heel, we put that blood on the filter paper. It then gets sent to the Maryland Department of Health Laboratory, which is located in Baltimore. We are a two-screen state. So the first screen is collected 24 to 48 hours of age and after 24 hours of feeding. And then the second screening is collected 7 to 14 days of age. We do screen for over 60 conditions, and I will let Carrie Ann continue when she gets to her slide. So I won't do any more because she has a great presentation for you guys. Next slide. All right, so the hearing screen, Maryland, we do follow the 136 timeline. And what that means is that we want all babies screened by 1 month of age. By 3 months of age, we want to know their hearing status. And then from that, we want them all to be in intervention services by 6 months of age. Here in Maryland, we have 75 to 100 babies that are born deaf and hard of hearing. So we have to do our part to make sure that we get them into services as soon as possible. Okay, next slide. All right. So Like I mentioned before, all babies should receive that newborn hearing screen. And that happens the initial one happens before the baby is discharged from the hospital. Okay. So that is something that happens directly at the bedside. More than 95% of babies born deaf have parents with typical hearing. So that means that the parents may just not know what to look out for. So that's where it's important for us as healthcare providers to really be a resource for those families. Um, when the babies are in intervention by 6 months of age, there is better language outcomes. So when we talk about making sure that repeat gets done in a timely manner, is because that timeline is so important. Next slide. And one of the things that we want to talk about, especially during this webinar, is what can you do as the provider to assist with this follow-up? I mentioned majority of the testing gets done at the hospital. So what is there that we can do? There's so much that you can do. One, just confirm that the hearing screen was done. If the baby failed the initial hearing screen, making sure that the follow-up was completed, making sure that the appointments are made, making sure that the family goes to those appointments, um, making sure that we don't say, oh, it could be fluid in the ears, because we never know. We want to make sure that diagnostic testing gets done in an adequate amount of time. Next slide. Okay. Now, we're going to hear this multiple times throughout the webinar, and you're going to hear it multiple times because we want to make sure that we emphasize that screening is not a diagnosis. Screening is just a screening, so there needs to be further testing completed. So either it's through an audiologist for a repeat hearing screen, or if it's through blood spot and going to whatever necessary specialist um, to get that diagnostic testing completed. Okay. Um, when we're dealing with the screening results, we don't want to be overly optimistic and have some false reassurance, because it is not a confirmed, it's just a screening. And we want to make sure that they understand the importance of doing that follow up. So if we do provide a false sense of reassurance, they may not schedule that appointment so quickly, or they may not go to that appointment so fast. So we don't want to provide that false reassurance, because we want to make sure that they get that follow up testing done. When you're also assisting a family, provide them with resources, resources that they're easily understandable. As a mother myself, I know that when you're in that room, that provider office room, stuff either goes in one ear and out the other, or just bounces right off of my forehead. So sometimes having something written so that if the mom has to make these phone calls, or if there's this resource, having it written so that when she gets home and she gets settled and emotionally calms down, she has something that she can reference back to, or has like a checklist that she can do, or that the family can do to ensure that they get those additional appointments or those additional resources to support them as a family. So that is just an additional tip. Okay, next slide. All right. So like I said, my slide is going to be very brief. And with that being said, we will roll right into our first speaker. So Carrie Ann Kupperman is a physician assistant in the lysosomal storage disorder program at Children's National Hospital Rare Disease Institute. She received her undergraduate degree from Johns Hopkins University and attended graduate school at Tufts University School of Medicine, and now lives in Maryland with her husband and 5-year-old son. She has been working in the lysosomal storage disorder department for over 5 years and sees patients ranging in age from newborn to adult. All right, take it away, Carrie Ann.
Awesome. Thanks, Portia. I'm starting my self timer here to make sure I don't
blab too much and keep it on point. But thank you so much for having me today. I feel really honored to be speaking to everyone today. This is a passion of mine, and I'm always happy to share some tips and just counseling advice, especially as a mother myself too. There's a lot that goes into this, and it's important to kind of step back at the end of the day and remember what we're doing this for and best practices to get there. Next slide, please. I do have some disclosures, and full disclosure, I really only work in lysosomal storage disorders. That is my bread and butter. You may have spoken to me, so I'm happy to see everyone who's here on this webinar. We also have Cecilia on today, who's just joined our team for Newborn Screen. So here at Children's National, we are a referral center, and we do get a lot of the referrals from the dry blood spot program, but there are also lots of other referral centers throughout the state. Next slide. Some objectives I wanted to talk about today. I just want to talk about what the newborn screen is and how we got to this place, some best practices for that dry blood spot sample, because we often rely on community providers and pediatricians to perform this. And there are some really just easy tricks to get a good sample to make sure we're not having to do repeat samples. Talking about counseling families of an abnormal newborn screen, just some highlights and some cases to kind of underscore some of the things Portia has already discussed. And again, screening is not diagnostic, so hammering that home, seeing how this plays out in real life. And if you remember nothing from today, that the PKU is not the newborn screen or newborn metabolic screen. I feel like newborn screen and newborn metabolic screen are being used interchangeably recently. I usually defer to newborn screen, but newborn screen, newborn metabolic screen, the PKU test is just part of it, and we all need to start making sure we use the same language for clear communication. Next slide. Again, you're going to see this a lot, but regardless, newborn screen really started in the United States back in 1963 for PKU, or phenylketonuria, and has since expanded. And historically, that is based on disorders that have been advocated and elected to the RUSP. And disorders on the RUSP are chosen based on evidence that supports the potential net benefit of screening, the ability of the states to screen for the disorder, and the availability of effective treatments for those. So each state is different. And here at our referral center, we actually don't get babies just from Maryland. We also do DC and Virginia. So we see a lot of different things and different ways different laboratories do things. And Portia, tips on this too, but we screen for so many disorders. So if we're looking for over 60 disorders, it includes a lot of different things. So kind of those big categories include the inborn errors of metabolism, SCID, hemoglobinopathies, cystic fibrosis, hearing loss, some endocrine etiologies, congenital heart disease, and spinal muscle atrophy. And this is all from that heel prick or dry blood spot test that's sent to a state lab that usually turns around in about a week or less. Next slide. So just some really key points. And again, I'm sure everyone here says, yeah, we know how to do a heel stick. But on the other end of it, we see a lot of unsatisfactory samples or samples that we're not able to even get a quantified number on for numerous reasons. So just some tricks that we learned if we do heel sticks here is if you have the capability, first apply a heat pack to that baby's heel for at least 5 minutes to increase blood flow. So there's those little baby heat packs that even have the wraparound tape that are really helpful in just getting that vasodilation right at the tip of the heel. You then want to make sure you clean the area with a sterile alcohol swab. Again, this might seem silly and really basic, but you'd be surprised some of the samples that we see. Then you want to puncture the heel with one of those single-use newborn lancets. And ideally what we do is we try and have a parent either seated up on an exam table or in a chair, have baby in their lap, and sometimes I'm even almost near the floor. You want to work with gravity to make sure you're using gravity to your benefit so that blood's flowing down, because sometimes those babies do not want to bleed very well. You can even, massage the leg and the foot, kind of, for lack of a better word, just milk that milk down into the heel bed to try and get that blood to come out. Another important step that I feel like a lot of people disregard is to wipe away that first drop. So you want to take sterile gauze Wipe that first bit of blood off and just throw it away. From there, you want to just drop the blood onto the filter paper. This is easier said than done. A lot of us do end up, getting the heel pretty close to that filter paper card, but you want to try and drop it so there is no contact. And you want to try and fill as many circles as you can if you're doing this from the heel stick. Again, really important, and I think it's overlooked. Once you have those samples done, you need to dry it horizontally for at least 3 hours minimum. So 3 hours plus. You want to make sure it's not underneath an air conditioning vent or a heater. You want to make sure it's not near a window. And ideally, it's around 64 to 77 degrees. You don't want to blow on it. Believe it or not, I've had lab techs whose parents have told me they've blown on the samples and then they're worried about DNA contamination. So don't blow on it. No dryers, no air vents, just let it sit and keep that flap open, okay? You no need to close it up, keep it open and have a dedicated spot in your clinic to be able to do this. Next slide. So not going into super detail here, over 60 disorders, it's a lot to screen and a lot of great screening we're able to do from just a simple filter paper card. But in bold are the big types of disorders, and then just listed underneath some of the subcategories of disorders. So Portia already really hit on the hearing loss and congenital heart disorders. I, of course, coming from lysosomal storage disorders, I'm used to proteins and enzymes. So I like to speak to that, but everything is applicable when it comes to that dry blood spot test. Next slide. All right, so we're all really busy. We see lots of kids, lots of phone calls, lots of charts, lots of notes. It's really important to step back and think about the point of view of our patients and our parents. So oftentimes these are newborn parents and they don't come with instruction manuals. So let's think about all these different families that are welcoming a new baby to their lives. They're discharged to home, don't know what they're doing, and they're recovering from a major medical event. The mom has lots of changing hormones, adjusting to a new family dynamic, lack of sleep. And that's just assuming there are no complications with extended NICU stays or anything like that. And then they find out their baby has an abnormal newborn screen. So again, recall that, a lot of these parents can be first-time parents, and just having a newborn is a really tough thing. And then, especially in this day and age, we have a lot of parents who come to the table with some form of genetic testing or in vitro fertilization. And in their minds, they thought their baby would be healthy. They thought they did all the things to try and secure a healthy child. Next slide. So let's think about some things now that might cause a newborn screen to be abnormal. Prematurity. So if babies are born really early and or just a low birth weight, we can see some abnormal analytes just because their body organ systems aren't working as a full gestational 39-40 weeker. Feeding in TPN. If a baby's on TPN, we might see some abnormal analytes. Doesn't necessarily mean a baby has a disorder, but we need to take that into consideration when figuring out our follow-up plan. If a sample is collected less than 24 hours, that's more indicative of mom's maternal enzyme, mom's body activity versus baby's. And then if a baby's lost to follow-up, or we forgot to do a newborn screen and we're trying to play catch up and make sure baby's safe and healthy and closing out by the time they're 6 months of age, they might flag abnormal just because that cutoff is more based on a baby who should be a day old versus 6 months old. There's also a lot of poor sample collection, problems with shipments, and then hot days. We live in the DMV, it's already getting hot out, and that heat actually degrades protein. So in our blood samples, we have proteins and enzymes. Enzymes are protein, and when there's heat, it denatures that protein and causes things to look lower than it really is in the human body. So during summertime, we actually get a lot of false positives for our enzyme assays. Doesn't mean baby has the disorder, but we still need to follow up on it. Also, poor sample collection. Sometimes if it's oversaturated or there isn't enough blood or there's contamination or it's abraded or scratched in some way, we just can't use that sample to get what we need. And then we also find babies who are carriers or have pseudodeficiencies. So in genetics, those are babies who do not have true disease or disorder, but they might flag on the enzyme test just because of that cutoff. It doesn't mean they have the disorder. And again, we just need to do second-tier testing to follow up on that. So I like to underscore to families this picture, and even pediatricians as well, as if we think about newborn screen of this big square, we're screening all babies that are born. And we have to throw a really broad net because we want to make sure we don't miss those babies that are in the bullseye. And the bullseye is tiny, but we don't want to miss even one of those babies. So to ensure we're not missing one of those babies, we're going to have a bigger catchment area. And this is what I try to explain to parents when they're really nervous or anxious and we just need to get a little more information or do a second-tier test, is that their baby may not have this disease or disorder. We just need more information because babies are too precious to miss this. Next slide. Again, you're going to hear a lot of the same things over and over again, but I think it's really important to remember that if a baby flags on their newborn screen, we don't consider it positive or negative. We actually just call it an abnormal screen. It is not within the normal reference range. It is abnormal, okay? And an abnormal screen is just a screen. It is not diagnostic. So you can see we're trying to get the bullseye, and that's hopefully when we get the diagnostic level, but the screening is this much. So we need further testing that's more specific to diagnose or rule out a disease or disorder. The biggest thing we all have is fatigue with emails and phone calls and portal messages, all of this information coming in. But the biggest thing is to actually interface with the referral center and with the family. So oftentimes, when I call a pediatrician's office, our protocol is Maryland will contact you first, and then we like to contact you next. And oftentimes I hear, you already called us. And I say, that was actually Maryland Department of Health. I'm calling from the referral center, and I want to make sure I speak to the provider that baby's healthy and that family's aware that they need to do some additional testing and that genetics will be calling them. Because you know who nobody wants to hear from out of the clear blue sky? Genetics. So if a family has been seeing a pediatrician, we very much rely on you guys to interface with the family to give them a heads up, because that can be a really scary call, especially if they don't even remember having the newborn screen done in the hospital. So parents want to hear from the PCP, and we want to talk to the providers who are familiar with these babies to really make sure there aren't any concerns. It's also okay to not know about these disorders. I am not up to date on how to treat bronchiolitis or the newest well visit screens for a 6-year-old. I'm just not. So we do not expect you guys, when you have so many patients and so much information coming in and out, to know these disorders. On the flip side, though, it's not okay to give incorrect information. So when in doubt, the best thing is to say, oh, it looks like this might have been abnormal. I might need to ask Maryland Department of Health or the referral center about some more information, but let's make sure we do all the follow-up that's needed. Because in the end, not everything is a false positive. Next. So I believe this is what the parents receive in the hospital. And again, when you have a newborn, there's so much going on. You're trying to figure out feeding, you're trying to figure out this new life that you're now responsible for. And oftentimes parents don't even know the depth of the newborn screen. So this pamphlet is great, but it really scratches the surface, especially when we start talking about genetic testing and other things down the line. So let's get into some cases. We can do next slide. So case one, and these are not Maryland for the most part. I think there's like one sprinkled in here. So we'll just put that out there, but this is from our experience. So case one is a parent calls everyone at their local genetics center demanding their child be seen as soon as possible. The pediatrician actually told mom that baby has a storage disorder and that it will affect the liver, kidneys, and brain. Mom is in tears when I speak to her on the phone, and she's saying that the pediatrician even told her it's definitely from mom because it's on the X chromosome. And then she broke down even further and talked about how her, quote, uterus exploded and had a very traumatic birth and recovery. So there's a lot to unpack there. And just from that synopsis, you can understand that that mom is going through a lot. So when I look at the baby screens that are available to me, the reality was there were actually 2 samples that they literally just didn't get a quantifiable number on for a lysosomal enzyme for whatever reason. But when that happens, then genetic sequencing is initiated in another jurisdiction. So that was just pending. That's all we knew. And pediatrician didn't have any clinical concerns for this kiddo. So the outcome throughout all of this was baby ended up just being a carrier for Pompe disease. No follow-up needed, no monitoring, nothing. So the facts here, and why we say, if you're not sure about something, keep it really simple, is Pompe is an autosomal recessive disorder, and it primarily affects muscle. So this poor mother who went through a traumatic birth is now thinking, I did this to my baby because this is inherited from me and it affects the brain and all of these things, when really baby wasn't going to be affected in any way. Next one. This one is 3 different babies that I'm showing under one case. All 3 babies had undetectable IDUA enzyme for MPS 1, okay? So baby A, their pediatrician was just difficult to get on the phone. Either we couldn't even get a hold of an administrative person, or we couldn't interface with the clinician directly. And the PCP told the family that there are lots of false positives and that this was nothing to worry about. When baby presented to us, she was in fulminant heart failure and had signs and symptoms of this disorder. And the outcome here was really severe MPS 1 that required a bone marrow transplant. However, because of this communication, we had to take a lot of time, unfortunately, convincing this family that this was a real result. It wasn't just a false positive, and that we needed to do something about it. And this led to a diagnostic and treatment delay in this patient. Now we cut to baby B. There were no clinical concerns from the pediatrician, but the family was told that the baby was positive for MPS and needed to be seen ASAP. There's a theme here, babies always need to be seen ASAP. And the outcome here was pseudodeficiency alleles. So these are gene changes that we know cause low enzyme in a lab when we check with artificial substrates that are available in labs, but it works just fine in the body. And these have been really well identified over time. So no further follow-up is needed for these kiddos. So that's kind of best case scenario with undetectable enzyme. But you can see that with pseudodeficiency alleles. Then we go to baby C. Again, no clinical concerns from pediatrician, but the PCP was demanding a visit while we waited for second tier testing. So I'm on the phone talking to her and saying, let's just wait. More often than not, it's nothing. We talk about it, and I keep saying, let's wait. If you don't have any concerns, let's wait till we have more information. And then she said, well, the parents are related by blood, and they each are carriers of MPS 1. And I almost dropped the phone and said, well, that changes things. And sure enough, this baby is at risk for a form of MPS 1. And last case number 3. This was a non-English speaking family. They didn't have transportation, and they actually lived really far away from our referral site. So sometimes babies live 2 or 3 hours away, and it's our job to determine acuity from there. And this baby just needed a repeat newborn screen. So I called the pediatrician's office, and I was told by both the lab and nurse manager that they couldn't perform a newborn screen, but they could do a PKU test and a bilirubin. So had to figure out where they sent the PKU test, which did end up being that jurisdiction's newborn screening test, and get that done. And baby did not have any lysosomal storage disorder, and it was closed out with no further follow-up needed. Next. So again, if we learn nothing from today, please remember that PKU is not the newborn screen. It's a part of it, and it's 1/60th-ish of Maryland's screen. So you can see in the green all these other categories we test for, and PKU is one of those diseases that we also test for. But together, that's what makes the newborn screen in Maryland, okay? And next slide. So newborn screen, when in doubt, phone a friend. Believe it or not, we all are in the interest of helping everyone, especially just making sure babies are safe and that babies are healthy. So Maryland Department of Health is always there to help field any questions. They also work really closely with the referral center. So even if you don't hear from genetics at Children's or Hopkins or wherever directly, they're often interfacing with us to make sure all the questions are being answered appropriately. So you never have to work in a vacuum or know all the information. We're all here to work together. It's tricky because you can't argue that all of these disorders have the same acuity. But at the end of the day, we have to treat each referral with the same acuity, meaning while we know that there are going to be false positives, we need to try and ensure we do everything we can to safely close out cases effectively. And that means treating each referral with the same acuity. All of this to say, we do identify a lot of babies who otherwise might have lots of morbidity or potentially pass away early in life. And even if we're not identifying those very acute disorders, we're avoiding really long diagnostic journeys for other patients who otherwise wouldn't be identified for decades from newborn screen. And that's it for me. I really thank you guys for all of your attention and here for any questions. I think I saw one pop up in the chat, but happy to also address those later too.
Thank you so much, Carrie Ann. Yes, there is one in the chat, but we will address it in the designated Q&A portion. So, but your presentation was fantastic. Thank you so much. So we are now going to hear from Ann Soltis. She is a caregiver of a child with a genetic condition. So Ann Soltis is a teacher, lawyer, mom, and wife. She received her BA and JD from the University of Notre Dame. She currently teaches at Rockbridge Academy, a classical Christian school in Crownsville. She is a mother of 4 children, aged 24, 22, 20, and 18. She is also a grandmother of a beautiful 6-month-old baby girl. Her youngest child was diagnosed with MCAD in 2006, but is thriving and healthy and about to head off to Wheaton College next year. With that being said, take it away, Ann.
Thank you. Thank you, Portia, for having me, and happy to be here. I'm glad I don't have to do my bio now that I had on my notes. So good afternoon. I just want to tell a little bit about my story and some of the pros and cons of how it went down for me, and then just thoughts as a parent, what might be helpful. So my son was diagnosed in 2006 with MCAD, which I'm glad I'm not going to pronounce it. So you guys know how to pronounce that way better than I do, but the acronym is great, MCADD. And it's just a fatty acid oxidation disorder. And I've had this letter with me like for 18 years that explains it to wherever I go, whatever doctor I go to. But basically, for those who aren't aware, it's just the idea that he doesn't metabolize things normally. And so when he fasts, it can easily be severe for him. And he could have coma and possible death if he ends up in that fasting stage. And so I received that news after my son was in the NICU for 7 days. So he had an on-time delivery, but had fluid in his lungs, and so had to be in the NICU for that. Was on the respirator for a day, and so I was like, I'm out of here. We conquered this, and then all of a sudden, I get this paper on discharge notice that he has this genetic disorder. And I had 3 healthy girls, never been to the NICU before, and then so getting that disorder, getting that diagnosis or the screen was pretty traumatic, and it's great that you guys recognize that. I think even as an experienced mom, I was 35 years old and had done the baby thing, and I knew the way it was supposed to go, and this was not going the way it had gone before. So even older parents can have quite the shock and emotion and experienced parents. So I will say, just from my experience, I didn't have a physician notify me of this or talk to me about it. So I realized this was 18 years ago. So hopefully things have changed a bit. But, I think being in the NICU is kind of a different experience also. So I really just had a nurse give me the paperwork. It was signing on the dotted line and giving me a number for University of Maryland genetics. And so that lack of personal connection with someone who understood it, at least had some knowledge of it, was kind of difficult. So I'll just talk about the pros and cons a little bit about that initial experience. I'm so thankful that the newborn screening exists, right? So never heard of MCAD. I've never met any other parent with a child with MCAD. And I realized that once we met with our genetic physician that 10% of SIDS babies had MCAD and died before we screened for it. So whatever the year was when they started screening for MCAD, it's great. We were so thankful once we kind of realized that, and having that information was really helpful. Like, it just put it in perspective. And I will say, our genetic physician, I don't know if any of you all know Dr. Carol Green, but she rocks, and she's probably the best physician I've ever dealt with. I'm 55 years old. In all my different personal experiences and 4 kids, she was really available and able to answer any questions. So I can't speak more highly enough for her. But and I understand you all aren't the experts in these genetic physician or genetic issues, but I know that you all can make a difference and do make a difference in parents and child's lives. So the time that she took with us, the compassion she showed for us, all the questions she answers was such a blessing to us. I would say just the experience for kind of the more difficult things, or the cons, if you will, is just I didn't really have anyone to kind of listen to me with compassion and understanding, and it was very just mechanical. You're released from NICU, and here's this diagnosis, and the whole idea of false positives, I don't think anyone really talked to me about it, but I was hoping for that, right? Like, oh, this has got to be a false positive. I'm sure it is, right? And so I think that lack of personal connection with someone was difficult. So just some of the encouragements as a parent looking back. First of all, I just want to say thank you for having me again, because my son is graduating from high school, and to be able to do this is just a blessing for me to share. But information is key. I know you're not all experts in those 60 diseases, but as much information as you have, information is power, right? And so sharing the truth of what you know and what you have seen before in your practice is just really helpful. And honestly, I would love to talk to any parent who's diagnosed with anything similar and be able just to tell them my experience. So I'm happy to give my contact information out, but I think it's really important for people to understand as much as they can, what is this screening? What is this? And while it's not always sure that they're definitely going to have this disorder, in the end, I think just giving them a little bit of information, if possible, what does this look like for the child's life? And obviously, just like in any situation, having compassion, recognizing that, yeah, as a mom, you have hormones racing, you're exhausted, and we just got out of the NICU, and that's just a hard place to be. Just practically, for whatever it's worth, the treatment, so to speak, for MCAD was for the first 6 months, I had to feed my son every 3 hours, like around the clock. So I was a nursing mom. He never took a bottle. So I literally had lack of sleep like you not believe, and taking care of 3 other kids on top of it. So, and then we had to have a carbohydrate at the beginning of the night before sleep, like really the rest of his life. and then IV D10 if he ever went into some kind of illness or some kind of surgery where he was fasting. But all that to say, having compassion for, yeah, this is a disorder that is something that could affect the rest of their lives, and being willing to just have that compassion and at the same time hope. So that's where I love to encourage parents and families too, because my son has never had a real problem with it. We've had to go to the hospital probably about 6 times to get an IV. And we've monitored and we've checked in with the genetic physician, but he's had a normal life. He's done well. And so I think it's encouraging for parents to know, one, this screen is a blessing, because the outcome before could have been death. Really could. It could have been SIDS. And now we know something, and now we know how to deal with it. So for me, I'm so thankful that we were able to deal with it, and even that lack of sleep, I'm thankful for, and because we were able to help him through it. So I know that some parents will go and I did this, search the disease on the web as soon as they get home, and this is a place where Dr. Google is not helpful, so just encouraging those parents to check in with the genetic physician. We did right away, and Dr. Green was like so responsive. We were able to get in, and so I think Portia was talking about the checklist of encouraging parents on what to do next. Yeah, just checking in, because I could imagine some parents, it might take a while for them to check in or get an appointment or whatever. So having somebody to walk alongside of a parent who's dealing with this is really a blessing. And I would say as a provider, also encouraging them that to reach out to their family and their support structure that they have too. I come from a faith background. I had people praying for my son as soon as we got out of the hospital. And so I'm thankful for those people and the support that I had. And I'm thankful to God that he got us through. But yeah, that's a little bit of my story. And like I said, I'd be more than happy to talk with parents who ever get a similar diagnosis or this diagnosis. And I am really thankful that you guys are putting this on today. So thank you.
Awesome. Thank you so much, Anne, and thank you so much for sharing your story. Thank you. All right. Next, we will hear from a caregiver that has a child with hearing loss. So take it away, Maisha Gilman, and I'm sorry if I mispronounced your name.
You're muted.
Yeah, you are muted.
Okay, there we go. Can you guys hear me? All right. Hi. Good afternoon. My name is Maisha. You did perfectly saying my name. I really appreciate the opportunity to tell our story in hopes that it can provide a different perspective and that you can use our experience to improve upon the care that you might give in the future. So, like I said, my name is Maisha, and I'm the proud parent of a 2-year-old perfect little boy who just happens to be deaf, and his name is Tiberius. For me, being a mother was so important. I grew up always wanting to be a mother, and we finally started trying without results. It was very difficult to get pregnant, but after more than 2 years of practice, we finally got pregnant just before my 40th birthday. We really didn't know what to expect, so we relied heavily on information from doctors and nurse practitioners, and not just providing the information, but the information why. Like, for example, we had previously agreed that we would not do prenatal genetic testing. We didn't want to get a result of our child having like this arbitrary percent of having this extremely rare disease and stressing us out. But when it was explained that testing for Down syndrome would be beneficial to educate the doctors for how we would give birth and be prepared for a different situation afterwards, we decided to go ahead and do that. Like, that made sense to us, but it was explained to us that it was a legit reason to move forward on why doing that test. So moving forward through the pregnancy, The screenings showed that our baby kept falling low on the low birth weight and weight scale. And though we brought this up as a concern, doctors and nurses always waved it off as such as like, oh, these are just guesses, like for size and weight, or smaller parents have smaller babies. By the way, I'm not small, I'm nearly 6 feet. My husband's nearly 6 feet, but that's besides the point. So our baby was never a big mover either. And so his heart rate screenings always showed like the fluctuation was very flat. And no one said anything. They were like, oh, it's okay. And this went on for weeks. And it wasn't until one doctor flat out showed us what our baby's heart rate screening should look like versus what our son's screening looked like, and very plainly told us that you can have this baby today or risk giving birth to a stillborn. That was like the reason why we're like, okay, we're going to the hospital. We're going to have this baby right now. So that was our turning point, and was like, oh, they're not joking. Like everyone been telling us like wishy-washy information. Oh, it's okay. Like giving us sort of like moving us along as in, this is not serious. Don't worry about it, until one doctor finally told us how serious this could be. So moving along. We immediately head to the hospital, and even then, when we arrive, the on-call doctor and the advanced maternal specialist were still debating whether or not to actually induce labor or go ahead with the C-section. And it wasn't until my heart rate jumped up, they're like, into surgery she goes. And that's how my perfect baby boy was born. So that's before, and just sort of the information. And I know you guys are probably not, this is not where we're talking about, but even before we had the baby, there was a lot of just information that was not clear. It wasn't proposed to us in a way that we could digest and understand. So for the next few hours for me were a huge blur, right? I just had a cesarean. My son Ty, that's his nickname, Ty, was taken into the NICU for low body temperature. So I recovered on one floor and Ty on another. And during our stay at the NICU, we noticed some little things that didn't really seem big, but we pointed them out. For example, he didn't cry. He would sometimes startle when you just appeared at the incubator. But, we didn't know what to expect. So we just brush those off as, okay, those are just normal reactions for this particular child. After his body temperature regulated, we stayed in the NICU as he had trouble with the breathe, suck, swallow coordination, and he was taking in very little calories orally. After a few weeks, when Ty was not making improvement at this particular NICU, we asked to move to a tier 3 NICU. There he was tested for everything under the sun. He had a physical when he arrived, and he was determined to have low tone. He was seen by a neurology team when they determined he couldn't hear. They determined that he could hear when they clapped their hands at his ear and he moved. He was seen by ENT. They confirmed that his vocal cords looked good. He had 2 MRIs, which they discovered he had a small malformation on his brain stem, but the team of doctors told us that they were not worried. So after 5 agonizing weeks and tests and tests and tests, we finally determined to put in a G tube because he was still not swallowing orally, and we were approved to take him home. As we were getting the discharge paperwork, one of the ends, he did the car seat test. One of the nurses mentioned that he still hadn't done his hearing screening. So they rushed around and found a tech who could sort of like squeeze him in, and just before we took him home. And that was the test that started the ball rolling on our whole life-changing experience. The tech performed the test and sort of brushed off the results, telling us, well, there's a lot of machines in the room, so those can interfere. And, you had a C-section, so it's probably related to that. And like brushed it off as, it's okay, it's nothing. So we take our child home. We work on getting him an additional professional hearing screening because we did not know at the time that we had been scheduled for one with the hospital. So we went around and did it. we had already been referred to infants and toddlers, so we informed them that he had an abnormal. I know you guys use the term abnormal, parents use the term failed. So we're gonna automatically change that in our head as he failed the hearing screening. And we even performed our own super professional, super like technical test by like dropping things behind him or or letting the dogs bark. And when we didn't get our results, we knew that this was probably not going the direction we wanted. So we got our second hearings screening from an outside party, and we called the hospital, the children's hospital, and their protocol was to schedule the second hearing test and the ABR at the same time. So they accepted our outside failed hearing screening, and we moved along to the ABR. During the ABR, I remember after the test, the screener left the room. She's like, I just want to confer with my manager. And she comes back into the room. The first thing she says was, are you already signed up with infants and toddlers? And at that time, as soon as she said that, it was clear that this was not going to be good news. But this was the first person that actually said, hey, this is the situation you're in. It's not going to be the one that you were hoping for, but these are the next steps. And that is where we're like, okay, like we go here, now we go here, and we're going to do additional testing, but it's probably going to end up being a bad or different, not bad, different situation than what we had expected. But that was the first person who like clearly laid it out and was not wishy-washy in her language. So our son is performing wonderfully. We got testing before he was in infants and toddlers, and he got language around 7-8 months is where he first started with the school that he's in now. He has language and he can clearly communicate. So that was where we finally got to a point, but it was a little bit of 8 months of pressure before he got to that point. So thank you for letting me tell my story.
Awesome. Thank you so much, Maisha, for sharing. Thank you. So I will roll into, I don't think we've gotten any other questions except for that one, which is it okay to use a blood collecting tube to get blood? Now, I can answer that question, but I kind of want to hear Carrie Ann's expertise.
So, not gonna lie, while I personally do the heel sticks, I don't do venipuncture. So we do have phlebotomists who do that. And some of our collection sites, they do the venous collection. And it's fine if you're collecting in EDTA tubes. From my experience, though, the only like acceptable collection is dropping it from the tubing onto the filter paper card. So about 1 drop per circle. I haven't seen using any tubes and then transferring, but Portia probably has some different boots on the ground experience with that.
Yes. So I agree with Carrie Ann. There are some facilities that use different blood collection tubes. Really, the preferred method is straight from the heel. Let me say that, straight from the heel. One of the things that you run into when you use other collection methods, including glass pipettes or anything else, is that you end up accidentally scratching that filter paper, which then would declare the sample as unsatisfactory. Okay. So I will leave it at that. Like the preferred method is directly from the heel. And when we see places using other methods, we do risk a chance of the specimen being unsatisfactory, which can then cause a delay with getting the newborn screening results. So that is my answer. Okay. Any other questions? Bailey, did you receive any other?
I don't have any other questions, but you can also, as an attendee, you can also raise your hand if you would prefer to ask verbally rather than in the chat. Carrie Ann?
Yeah, I just wanted to take the time to thank Anne and Maisha for sharing their stories and perspective. I really underscore what you guys echo in terms of that personal touch. And that's where I feel like these referral centers really come into play. Carol Green is an incredible human. And I think we all who work in this space now try to work as hard as we can to be in communication with families as early as possible. So even though I don't do those acute MCAD and other disorders, I'm still calling families within 24 hours of them getting that news, because I know what it's like, right? It's not, you're not going to sleep through the night and you're going to look at Dr. Google. And when you look at Dr. Google, even with AI these days, what comes out is usually really terrible, not correct stuff. So I and others I know try to get ahead of that in terms of these are the possible outcomes from our experience. This is maybe likely what we're looking at. We just don't know. But we try and reassure, we just want to keep babies healthy. So let's be in close communication. And I do feel like, or at least I hope, Anne, that that has changed over the years, because that just sounds like a terrible experience you had. And unfortunately, I don't think it's not uncommon where it's just kind of machinery of, oh, it's time for baby to go home, do car seat tests, get them home, you name it. And I want you both to know that we appreciate you and your stories, and we do what we do and try and help families like you every day and always work to be better for that human connection too.
Yes, thank you. And just one other thing too. It's interesting, even parent support groups on these things can be difficult, right? So I remember doing that. I was like, oh, this doesn't help me at all. So it really, yeah, I just appreciate all that you guys are doing. Just even having a webinar like this shows that you're trying to do your best with this. And yeah, I mean, sitting down, and I will say what one of the things that makes Dr. Green so good is that she's willing to give time. So I know it's hard. I mean, we're all busy, right? But the ability to look someone in the eye and give them time, even be late for the next appointment, you could be making an impact on that person far, far bigger than you realize. And I think in our social media, internet world, those personal connections make a huge difference. And I just know for myself, this was a completely manageable disorder. And it's just so important to have that personal connection.
Yeah, and Carrie, I just wanted to comment, and then I will close us out. Is that yes, us in the medical profession, we do get a point where we become very robot. And we forget that there is a family behind what we're doing. And it's so important, especially in people in like my position, to bridge those gaps. Coming from a bedside nurse, I didn't know the rest of the newborn screening process. So I would just do it and it check mark. But now really having that clear understanding, it's like I want to bridge those gaps. Here at the Maryland Department of Health, we want to bridge those gaps. And that is why we wanted to conduct this webinar and our future webinars. Because when everybody has that knowledge, it builds a stronger community for our Maryland families. And that's what we're doing here. So thank you again, Carrie Ann, for sharing your time, your knowledge, and your expertise, as well as your experiences. Those cases were wonderful with us. And a special thank you to Anne and Maisha for coming and just sharing. I know when you come and share and talk, it's like you're reliving that situation over again. So we appreciate you taking your time out of your day to share with us so that we can learn from your experiences. So clear, compassionate communication is essential to supporting families throughout the newborn screening journey. And we hope today's webinar gave you tools and insights to carry forward as you care for your families and in your daily work. If you have any additional questions or you would like to access the resources mentioned today, we do have some resources in the slides, as well as just kind of picking the brains of our speakers. Please definitely let us know. We will have our contact information as well. We also welcome your suggestions for future webinar topics. So again, when you're reaching out, please let us know because we want to ensure that everyone has the knowledge of the newborn screening process. So thank you again for joining us and have a good rest of your day.
Thank you.
Thank you.
Thank you.